Good morning. Good morning. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering in New York, and are delighted to welcome you this morning to the Thank Foundation's International Thyroid Tumor Board. If I can have the next slide, please. We have a wonderful expert panel here with us that is going to, it's 8 o'clock. That's very good. In New York City time, because everything revolves around New York City time. That's the way we do things here. So we've got a wonderful panelist. We're going to work through 3 cases that I think have a lot of clinical relevance and will be very interesting. I'll have our panelists just quickly introduce themselves. We'll just go down the list here, starting with Dr. Hartl.
Sorry, hi, can you hear me? I'm Dana Hartl. I'm trained as an ENT and I do head and neck surgery at Gustave Roussy Cancer Center just outside of Paris, France.
Very good. Dr. Pitoia.
I'm Fabian Pitoia from Argentina. I'm an endocrinologist. I work in the University of Hospital Clínica from the University of Buenos Aires.
Dr. Brandwein.
Hi, I'm Margie Brandwein-Weber. I'm a head and neck pathologist. I'm a site chief at Mount Sinai West, part of Mount Sinai Health System. And I work with Mark Urken.
You poor thing. Dr. Rossleigh from down under.
Hi, I'm Monica Rossleigh. I'm an internist who's trained in both nuclear medicine and management of thyroid disease, and I work at a university teaching hospital in Sydney.
Beautiful. Thanks, Monica. Dr. Khorsandi.
I am a neuroradiologist, work in New York City, site chair of radiology at New York Eye and Ear, and my specialty is ENT.
Beautiful. Thank you very much. Dr. Urken.
Yeah, I am a head and neck surgeon here in New York at Mount Sinai Medical Center, and I act as a foil for Dr. Tuttle.
Welcome to my life. Dr. Tarasova.
My name is Valentina Tarasova. I'm endocrinologist at Moffitt Cancer Center in Tampa, Florida.
Fantastic. Thanks, Valentina. Okay, so the way this is going to work is Dr. Tarasova is going to present the first 2 cases with us. She's also a fantastic thyroid person, so she'll be a panelist with me as well. She just found that out. So let's start with case number 1. Show the slides for case number 1. And Valentina, tell us what you got. Next slide, please.
So today, the first case that we'll discuss is thyroid cancer management during pregnancy. So next slide. So 26-year-old female who was found to have palpable goiter on physical exam. At that time, ultrasound of the thyroid was done, and in September 2019, it showed bilateral thyroid nodules and some thyromegaly. Next slide. So here are the nodules, and she has bilateral thyroid nodules, 2, one on the right, one on the left side. On the right side, thyroid nodule was measuring 1.7 centimeters. It was solid with hypoechoic areas. Margins were rather smooth, and it was characterized as Thyroids 4. On the right side, the thyroid nodule was measuring 3.7 centimeters, and it was heterogeneous, slightly hypoechoic with lobulated margins, with possible some microcalcifications, which we cannot really see well on that representative slide, but it was characterized as Thyroids 5. Next slide. At that time, she had biopsy of both nodules, right 1.4 and left 3.7 centimeters, and both come back as Bethesda category 6 malignant. A firmer genomic sequencing classifier determined that she has BRAF V600E mutation. We're not sure why that was sent. It was done outside, but now we know that both of them were BRAF positive. On the day when she was found that she has papillary thyroid cancer, she was found she's pregnant with her 2nd child. So she came to appointment with her mother, with her husband, with her 1-year-old son, and of course everybody was very worried about that new diagnosis. Just of note that her thyroid nodules were symptomatic and she did not experience any symptoms of hoarseness or dysphagia, no shortness of breath. She felt them, but they were not really symptomatic. Next slide. There was no history of radiation exposure. Her maternal aunt was diagnosed with papillary thyroid cancer, but did really well. So at the time when I saw her, she was already 10 weeks pregnant, and at that time we obtained ultrasound of the thyroid and neck, and the ultrasound of the neck did not reveal any suspicious lymphadenopathy. Thyroid nodules at that time remained grossly stable. We also did fiber optic laryngoscopy, and we found out that her vocal cords were mobile and she did not have a vocal cord paralysis. So she was there for discussion what to do with her now biopsy-proven bilateral papillary thyroid cancer that was BRAF positive. And of course, she read about it all and she was quite concerned about the new diagnosis. Next slide. That's called ultrasound of the thyroid at 10 weeks. And it basically showed grossly stable thyroid nodules, and there was no really like worrisome lymph nodes to show on the imaging.
Okay, perfect, Valentina. Dr. Pitoia, I'm going to come to you. 26-year-old lady. You know, we watch a lot of these small thyroid cancers during pregnancy, but this is a 3.7 centimeter nodule. So when you see, I mean, she's obviously devastated. You get pregnant and cancer at the same time. You know, talk to me how you sort of set the stage for her. What do you present to her when you meet her the first time, Fabian?
Well, probably I will try to calm her down and calm the family down, trying to say that we are not in a rush in this case, and of course that there are some cases that escapes from the what we usually see, but we have clearly seen that thyroid cancer during pregnancy probably does not have a worse outcome than thyroid cancer during outside this time of the life. So probably I will try to talk with the patient, with the family, and try to calm them down and decide together which pathway we should go together with the decision, putting clearly that we do not need to rush in this case. We wouldn't indicate surgery probably from our side to a patient with this situation.
Dr. Tarasova, how did you factor in this BRAF positivity? I mean, everybody always worries about BRAF. Did that change, Valentina, how you were thinking about it in terms of watching or not?
From my standpoint, I definitely took in consideration in terms of like I was certain that it would be papillary thyroid cancer. We know that 63% of papillary thyroid cancer BRAF positive, and from my standpoint, it's basically as saying that it's classical papillary thyroid cancer and does not necessarily upgrade the risk. Yes, we'll know that it will present with some probably lymph node involvement. We know that there will be lymphatic involvement, but in the absence of other mutations, I think that this is represents classical papillary thyroid cancer.
Dr. Hartl,
So
what do you say when she comes to see you, Dana? You know, these are pretty good sized papillary cancer nodules. I'm sure she can probably feel them.
Yeah, I do the same. Fabian says you try to calm them down first, and you say that the prognosis is good, and then you say we can operate if they're really worried. We can operate during the second trimester. But personally, as a surgeon, it's, you know, they say there's no risk, but there's never zero risk in surgery. And so as a surgeon, even if it's palpable, she has no lymph nodes apparently, I would really try to reassure them that we're going to follow during pregnancy and operate after pregnancy, even after, you know, a few months if she wants to breastfeed, with no change in her prognosis. I would actually, as a surgeon, I would really try to get them, the family, to wait until at least she'd had her baby.
Hey, Mark, if she really wants a surgery, I mean, the GYN guys tell me we know how to do anesthesia with GYN, but from a surgical perspective, are you going to do the same surgery? Are you going to be more careful? I mean, just from a real practical approach, operating on basically two patients at the same time, does it change how you do it? How do you think about that if she really wants a surgery done?
Yeah, no, I don't think that there's, from a surgical perspective, I don't think there are any differences here. From an anesthetic perspective, I would have to defer to my colleagues, but at the end of the day, having done just a handful of these surgeries during pregnancy, it really follows pretty much the same approach here. Yeah, I would just ask the panel just quickly, is there any other mutation that would change their approach? Or is there anything that would modify your approach if your follow-up ultrasound showed X?
Dr. Pitoia, what do you think?
I was thinking, because I wanted to ask Valentina about why this patient get the BRAF before or at the same time of the diagnosis of the papillary thyroid cancer. This is something we never do here in Argentina. It's practically impossible, but well, it adds an information that probably gets nervous to the patient if he Googles what BRAF means and all that. So what was the idea of performing the BRAF in this patient?
She basically already came with this panel. That's not typically what I would have done. So, and yes, so that's she came with that result. So that's not standard of care. Let's put it that way. I think that once.
Yeah, Dr. Hartl, to follow up on Mark's thing, what would be the things if you saw somebody that was pregnant that you would say, no, I really think you should move toward a surgery? I mean, it's an unusual circumstance because I think we watch most of these, but when you're looking at the ultrasound, when you're looking at the patients, what are you thinking about from molecular or anatomic that you'd say, no, this is one of the unusual ones that should go to surgery?
That's a tough call because I would say maybe anaplastic if it's operable. Okay. Something, even because if it's in young people, it's mostly classic papillary anyway. And even if she has recurrent nerve paralysis, even if there's posterior extension, even if maybe, you know, tracheal invasion, I'm not sure that maybe I would be a little bit more wary if it were locally invasive to leave her for 6 or 9 or 12 months with it, maybe. But even so,
part of we struggle because I just asked you about a case that doesn't exist, right?
Right,
Somebody in childbearing age that's got anaplastic or poorly differentiated. Now, I occasionally see ones that have a lot of lymph node metastasis, you know, N1B disease. You're comfortable following that N1B disease as well?
Yeah, that's because if it's classic papillary, you get those big cystic lymph nodes. For me, anyway, they hang around for a few months, and that doesn't bother me. But
okay, let's go back to the slides, Valentina. Tell how this worked out, and then we'll look at her post-op stuff quickly.
So thankfully, actually, the patient was comfortable with the observational approach, and we saw her after she delivered the baby. She came with at that time we again obtained ultrasound of the thyroid and neck, and there was no any progression of her thyroid nodules, and there was no new lymphadenopathy. They probably slightly evolved in their appearance, but overall they've been stable. Next slide. Here I plotted all the numbers, the 3 ultrasounds that she had during the pregnancy. The first one 7 weeks, the second one is 10 weeks, and then the other one was one month postpartum. And overall, they're stable. And here I calculated some tumor volume doubling time. So of these nodules, and we see that overall it's 2 and 1.5 years. So they were somewhat progressive, but not definitely rapidly growing.
Okay.
So she eventually went to surgery, and she had total thyroidectomy since there was no presence of any lymph nodes. We did not do neck dissection, lymph node neck dissection. So she had papillary thyroid carcinoma, classic variant, bilateral. The largest focus was 3.8 with lymphatic invasion, no vascular invasion. It was confined to the thyroid without evidence of microscopic or minimal extrathyroidal extension. It was fully resected, negative margins were negative. Only 1 lymph node was resected, and it turned out to be negative. And she has also evidence of focal lymphocytic thyroiditis in the background. Next slide.
Let's have Dr. Brandwein weigh in here. I mean, it's always hard when we give you slides on a computer, but what are we supposed to be seeing here, Margie?
Not even. I was told to find a ringer for this case, so I have to accept what I was told. And so here I'm just showing you, one image of a ringer for classic PTC. And so, if that's a reasonable diagnosis, was there a tall cell component that was not appreciated? I don't know. I didn't see it. Is it really no extra thyroid extension? I don't know. I didn't see it. So what we're seeing here are the classic fibrovascular cores, and I can't point to them. But basically, the definition of a papillae versus follicular variant will be that you have PTC cells that are formed around a fibrovascular core, which is sort of finger-like. The importance of that comes in other issues like when can you call something nifty P, or when can you not call it nifty P because you're already seeing papillary formation. So that's all I'm going to say about this case.
Very good. That's beautiful. Yeah, because we did ask just for the audience to like show representative slides so we can see what these look like, which is helpful to me. Okay, last slide, Valentina, take us to the end here. How'd she do?
So she did really well. The surgery went well, no complications, no hoarseness, no hypercalcemia. She was started on thyroid hormone. 6 weeks after surgery, her TSH was slightly elevated above our goal. Her thyroglobulin was also slightly low detectable at 1.1 negative antibodies. At that time, we increased the dose of thyroid hormone and we did not recommend radioactive iodine. She came back 8 months after surgery. Her TSH looked better, even though probably will be adjusting the dose slightly, and the thyroglobulin looked better as well. There was no evidence of suspicious thyroid bed nodules or worrisome lymphadenopathy on the follow-up ultrasounds. So we still did not recommend radioactive iodine, and she will come in another 6 months.
Beautiful. So even though this is about pregnancy, I can't help but asking about radioactive iodine. Dr. Pitoia and then Dr. Rossleigh. Fabian, assuming the path report's read by your guys exactly what we're seeing here, radioactive iodine, yes or no, or maybe?
No, we will wait. We will follow the dynamic risk assessment for this patient, and mainly considering that she is lactating and probably she will need like 1 year of a good relationship with his boy or girl, baby. We want to keep that and be careful with giving radioiodine very fast. We know that this patient has a low risk, probably low intermediate or low risk of recurrent papillary thyroid cancer with an indeterminate response to treatment. So we will be very comfortable waiting for a structurally complete response of around 2-5% probably during long-term follow-up. And mainly we will expect lymph node adenopathies in this patient. We will not expect distant metastasis. So we will take it very carefully, and the trend of thyroglobulin going down is even more reassuring to wait this situation of administering radioiodine.
Monica, weigh in here for me, because clearly the endocrinologists are becoming much more less using like adjuvant therapy in this setting, but the nuclear medicine aren't necessarily on board. What do you think about this one, Monica?
Well, I think at our institution, she would have been operated mid-trimester. It's a big nodule, 3.8 centimeters. That's pretty close to 4, which, puts her in a higher. And at our thyroid surgeons would do a central neck dissection. So we really have no understanding of what's going on in her lymph nodes. And there was lymphovascular invasion. I'm not saying she would get radioactive iodine straight away. We would be happy for her to have breastfeeding, but she may well require it in the future, and we would wait at least 3 months after cessation of breastfeeding and assess her clinically on follow-up.
Fantastic. So I think for the audience, this is one that I think you'd get. Some centers really thought they definitely do radioactive iodine, other centers not, but the trend has been toward a little less use of radioactive iodine these days. So I think we're good. All right, let's move on to case 2. Valentina Tarasova, you've got a case now. This is thyroid globulins that can't be found in Florida. Is that what the story is?
Yes, pretty much. So a case of persistently elevated thyroglobulins. So this was a 38-year-old female who presented with progressive goiter. In October 2017, she had subtotal left hemithyroidectomy. Pathology showed 6 centimeter well-differentiated classical variant papillary thyroid carcinoma. It was encapsulated with capsular invasion, angiovascular invasion was present in more than 4 vessels, no lymphatic invasion, no minor extrathyroidal extension. My understanding that the plan for surgery originally was to remove the whole thyroid, but I think that the surgery was aborted due to recurrent laryngeal nerve damage because it was inadvertently torn during the traction of that goiter, and she basically had just lobectomy done for that cancer.
Okay.
Next slide.
Let's pause right here for just a second. Stay on the slides here. I'm sorry. Go ahead, Gabby. There you go. Slide 17. There you go. Yep. So we asked Margie this concept of capsular invasion, angio invasion. We struggle to know exactly what that means. So I think you've given us some examples here, Margie.
Right, here's another ringer. Now, this is not a 6 centimeter lesion, but it's a very nice ringer because it shows you the whole small lesion with a very well-defined thick capsule. Now, the thicker the capsule, the more concerning it is for invasion. Same goes with calcification or ossification. If we see calcification or ossification in a capsule, we're even more concerned for invasion. That doesn't exclude the possibility of invasion in thin capsules, but this is an association that we all know and love. Now, if you can look at low power at the interface between the capsule and this PTC, you can see already the irregularities just at low power. And so if somebody woke me up in the middle of the night and showed this to me, I'd say, oh, I bet you there's invasion, right? Okay, fine. So, so we have both capsular and vascular invasion. Advance, please. And I thought I'd just take a moment to show you other ringers and talk about the diagnosis of vascular invasion. So in the olden days, we could be lazy and classify lymphovascular invasion as one concept. And here it's very different in thyroid, right? So lymphatic invasion, you know, usually means that the lymphatic, there's real emboli within lymphatic channels. There is another definition to that term, which I'm just going to mention as an aside. We can see intrathyroid invasion through the thyroid segments, which represents intraglandular lymphatic invasion. Okay, now let's talk about vascular invasion. So now we need to be very specific about if something's in a lymphatic space or a vascular space. And here I show you like a, you know, perfect textbook example of vascular invasion. You don't have to look at the nuclei here. Here the nuclei don't tell you that it's whether or not it's PTC or follicular carcinoma. And in fact, you know, this might be from a PTC, which often has nuclei that look like follicular carcinoma. But look at the large vascular channel. It's obviously vascular, not lymphatic because of the RBCs. And the emboli are basically stuck onto the wall of the vascular space. And the shape of the emboli is very different from the shape of the vessel. That's important because more often what we really see is retraction artifact. And so the reason for discrepancies between pathologists, if one person says yes, another person says no, is that there may be an over-reading of retraction artifact. Okay, let's go to the next slide. So you may have in your reports, you know, things like levels pending to rule out vascular invasion. And so that's what I'd like to show you here. If you can look at the first two panels, you'll see there's vascular space and some lesional tissue, but it's not clear if the lesional tissue is just kind of pushing into the vessel and deforming it versus the being actually a real embolus within the vascular space. And so if you look at panel 3 and then you look at the panel 4, it took levels in this case to be able to demonstrate convincing vascular emboli. And so that's what I'm taking the time out to show you now. And so again, here you see it's stuck onto the wall, meaning it can't be some kind of floater that's masquerading as you know, an endovascular embolus. It's stuck onto the wall and it's a different shape than the vascular space, meaning it can't be a retraction artifact. Good.
Very good. Thanks, Margie. Okay, pause for just a second here. Dr. Hartl and then Dr. Urken. So this is a 38-year-old female 6-centimeter tumor, ipsilateral nerve was damaged or torn or whatever language we want to use. What are you thinking about? This is somebody that we're going to want to do radioactive iodine. It's a big tumor. There's vascular invasion. What do you tell the family about the next surgery? Because these are always done at an outside hospital. So outside hospital, then coming to see you, Dana. What do you tell the family about the surgery?
As usual. Well, yeah, I try not to downplay the possibility of a tracheostomy. So I do say that. I also say the risk is pretty low because we're an experienced center. We're going to be using neuromonitoring, eventually other techniques of neuromonitoring, but we can't exclude that there is a risk. In general, if she needs a tracheostomy for bilateral recurrent nerve paralysis, it's temporary because there are also ways of treating with the laser, for example, with our larynx to be able to decannulate most patients in these cases. I would look at her vocal folds though, and see like where the position is of the paralyzed one, because that might give us, if it's really in the midline, then there's maybe a little more risk. And if it's lateralized, if it's atrophic, then even if the other vocal cord is paralyzed, there's maybe some space. But so I wouldn't downplay it, but I wouldn't try to scare them either. I would say there's a risk, it's low, there are lots of things we can do afterwards, it's going to be temporary.
Dr. Urken?
Yeah, I don't think there's much more to add than what Dana has said. I think you got to be totally upfront, talk about the potential risk, it's small, and the what if, which hopefully won't come to pass here.
Okay, Gabby, let's go back to slide 20. Valentina, pick up. So we're now after the surgery, your initial workup here?
So we did ultrasound of the thyroid and neck and showed that there are multiple nodules on the right side of the thyroid, and there was some indeterminate level 5 lymph nodes. We biopsied them, so there was no really lymph node involvement. CT of the neck again showed some indeterminate small lymph nodes, and the CT of the chest prior to surgery did not show pathologically enlarged mediastinal or hilar lymph nodes. There were 2 sub-centimeter pulmonary nodules, 4 and 3 millimeters. There was some soft tissue attenuation in the anterior mediastinum, which was thought to be thymus, indeterminate enhancing 1.8 centimeter hepatic lesion and lipomatous lesion of the abdominal wall. So there were technically multiple candidates to represent metastatic disease in that case. So she had completion thyroidectomy and no cancer was found on the remaining lobe. To further characterize that hepatic lesion, we obtained MRI of the abdomen, and it was, even though it was not really met all the criteria for focal nodular hyperplasia, but based on the MRI characteristics, that was suggestive this diagnosis. But so next slide. That was her preoperative thyroglobulin. So TSH was 1.5 before surgery, and after surgery, her thyroglobulin was 158 before surgery, and after completion thyroidectomy, it went down to 37. So definitely there's evidence of something going on somewhere.
So Dr. Pitoia, what are we missing? So this is that thyroglobulin of 37 is 2 months after surgery. So we've got our nadir. The chest CTs and all that stuff was kind of non-specific. What are you thinking about 2 months with a thyroglobulin of 37 not stimulated?
Well, I would be worried, thinking that probably there's something outside the thyroid bed or the neck with that thyroglobulin, and of course with an intermediate high-risk patient, I would choose to administer radioiodine activity or radioiodine dose for this patient. Of course, these inspecific findings are not possible to discard completely. You cannot say, well, you do not have a metastasis in the lung or in the liver. It's extremely infrequent to find a metastasis, but you cannot say no until you do not have more follow-up of these patients.
Yeah, Dr. Rossleigh, obviously this patient's coming to you in nuclear medicine. Does the fact that she's got a thyroglobulin of 37 versus like if she came with a thyroglobulin of 1, does that impact sort of how you're thinking about doing diagnostic scanning or radioactive iodine or dosimetry? How does that change what you would normally do?
Well, the thing is, in our institute, if I get a referral from one of our thyroid surgeons, I know there's not going to be much tissue left in the neck. So I actually don't do preoperative iodine scanning unless it's an external surgeon that I am not familiar with.
Yep.
And unfortunately, we don't have dosimetry available in our institution, but that is a worry, that high dose. So I would err towards a higher dose rather than a lower dose.
Okay, and by higher dose, probably 150 millicuries or something like that?
150, yeah, 150.
Okay, so Valentina, we're all worried about little stuff. Let's take us through the rest of the story with the radioactive iodine and see where we are.
All right, so she received 200 millicuries radioactive iodine prepared by withdrawal, and she had suboptimal preparation. She did not really follow strictly low iodine diet, and basically, but her TSH was at the proper levels for radioactive iodine therapy. So, and here is her post-therapy scan, which was right as they did not show evidence of radioactive iodine avid metastatic disease in the lungs or bones. So some residual uptake in the neck was seen. Next slide. Her TSH, that in August 2019, her TSH went to 130, and then her thyroglobulin, interestingly, was not as sensitive to that elevation of TSH. So after that, 6 months after radioactive iodine therapy, if we can go to previous slide, her thyroglobulin remains to be elevated at 26.9. It's slightly decreased from the baseline, so somewhat of that was probably due to that remnant uptake in the neck, but it's still 26, so it's still there is something else going on. Next slide. So we did ultrasound of the neck, which again did not show any worrisome finding in the neck, nothing in thyroid bed, no suspicious lymph nodes. CT of the neck and chest with contrast, no metastatic lymphadenopathy. There was some development of patchy ground glass opacities in the right upper lobe. There was not really significant comment on these small pulmonary nodules on that CT scan. They were definitely below my resolution of resolution of my assessment. We did MRI of the abdomen to follow on that 1.8 centimeter focal nodular hyperplasia, and again, it was stable. But at that time, she had T2 hyperintense lesion at T11 that could represent osseous hemangioma. It was stable at that time, but again, this is since we did not have the source of the thyroglobulin, we were concerned about the possibility that could be that lesion that was producing the new bone metastasis. So another ultrasound of the neck showed some bilateral upper neck level 2 lymph nodes that were not highly suspicious at the time. Next slide. So in another 6 months, so we're already in 2020, the left level 2 lymph nodes became more prominent, and that's why trying to understand where thyroglobulin is coming from, I did the biopsy of that lesion, and it was benign. Because of that T11 lesion, I did the bone scan, and it did not show evidence of metastatic disease, just showed some degenerative changes. Next slide.
Okay, let me skip ahead a little. Let me skip ahead a little bit for time. Show me slide number 28, Gabby. So on slide number 28, she gets another 150 millicuries of radioactive iodine. Yes. Slide 29, Gabby. And Valentina, again, nothing here.
Nothing here.
Okay, and then slide 30. And this is where we are. Okay, and that's where she is now, Valentina.
Yes, so she was at thyroglobulin. Her thyroglobulin is actually does not correlate well with the TSH levels, as we can see that it's really not stimulated with a high TSH, and even with suppression it fluctuates. So sometimes, we can see 2 radioactive iodine therapies highlighted in red, and then her thyroglobulin went all the way up to 70, and interestingly with stimulation it went to 46, it went down. And then after radioactive iodine, her thyroglobulin was at baseline at 70. and then with appropriate suppression, it went down to 46.
So Dr. Pitoia, we got a 38-year-old female that easily could have distant mets, right? This was a 6-centimeter tumor with vascular invasion, so she's high risk for that. But we've got this thyroid globulin that is not TSH responsive, doesn't really seem to be trending, kind of bounces around, and still non-specific findings. So she comes to you now. What are you thinking now, Fabian?
Well, I will put in doubt this thyroglobulin value, because we have seen a couple of patients like this with expected this patient may not have enough TSH receptors in their cells, and then they cannot be stimulated to produce more thyroglobulin. But this is very, very strange and has not been shown. What it was shown is the presence of human anti-mouse antibodies or heterophilic antibodies that may give this pattern of non-stimulating thyroglobulin always the same, with TSH of 130, 40, and then with thyroglobulin 0.1, 30. So this is not something that I will look at very well, and probably I will try to keep doing new tests with a different assay to know exactly if there is this interference. And additionally, I probably use a PET-CT scan at this moment to better characterize the extension of if this is a real metastatic disease.
Monica, the role of 18-FDG PET scan in chasing these?
Yeah, well, I would have, before the second dose, when she was TSH stimulated, you could do a PET scan in the morning before you gave her the second dose. So she's got a biochemical incomplete response. I don't think there's any point at this stage giving more radioactive iodine. And an FDG PET will show dedifferentiated disease. So it's like a flip-flop. If there's nothing on iodine, you may find something on FDG. The other thing is that thyroid cancer often doesn't show up on bone scanning. So bone scanning isn't very sensitive for metastatic disease in thyroid cancer. As far as the liver lesion, you could do a hepatobiliary study, and that can be quite diagnostic in the focal nodular hyperplasia. And that's a pretty simple test.
Yeah, I agree. I worry that we're getting fooled with the thyroglobulin assay, Valentina. You know, you got a high risk patient, so you just, you know, if this was low risk, you'd feel comfortable ignoring it. So when I see these thyroglobulin numbers that don't really track at all with TSH, and they tend to bounce around and they're not really growing, that does make me wonder if we have some false positive antibody messing up our thyroglobulin assay. You know, it's usually lower, but an endocrinologist love blood tests, and we love to rely on our blood tests, but every once in a while you have to take a step back and say, are we missing something? The other scenario I've seen like this is she's just got really small volume pulmonary metastasis that we just haven't seen yet. They're not poorly differentiated, so unlikely to pop up on the PET, but we've seen cases like these that we've chased for like 5 or 10 years, and then eventually they say new pulmonary nodules that are 4 or 5 millimeters. So I was wondering these guys if sometimes we're missing just low level background pulmonary nodules. Margie?
Yeah, I was just going to say, it was kind of weird. Decades ago, I saw autopsy lungs from a young woman. I don't remember why she died, but she did have a history of PTC, and there were all these tiny little nodules, you know, in the lungs that she died with, not of.
Yeah, yeah, and we see, particularly in this kind of case, this is the typical case. 15 years later, I find it in the lungs. Vascular invasion, 6 centimeter, young people. These are the ones that should have concentrated radioactive iodine, but for whatever reason, she didn't. They don't explode, they don't get out of control. The PET scans are usually negative. And then sometimes when we find their disease down the road, then we put them down sort of the redifferentiation trials to try to make radioactive iodine work better. Last thoughts on her, Valentina? You've spent a lot of time with her. What are you guys sort of thinking of her?
So I think that I think that once we encounter patients with biochemical incomplete response, I think initially we have very limited information, so that makes us quite uncomfortable, and we try to understand where disease is. But once we did all various studies and observed for a couple of years, that definitely tells us that there is nothing really rapidly growing, not really evolving. So clinically, whatever it is, it's probably not as meaningful to the patient. So I definitely will slow down the follow-up, and that will definitely, she will have long life ahead of her. So I definitely will not be chasing that pulmonary nodules every 6 months with a CAT scan, even though probably it will be, I'm curious to know how they are, but like I have to balance the exposure from radiation and really for what imaging modalities will be actually meaningful and helpful in terms of determining plan of care. So I think that, and I definitely seen all that trend and analyzing it further, I think that definitely there is something wrong with her thyroglobulin level, and I will be much more conservative in terms of the follow-up of that patient.
Yeah, I think you're exactly right. These are challenging because the patients worry about it, their husbands and wives worry about it. Honestly, I worry about it every time I see them, thinking, what am I missing, and going back through everything. So, all right, very good case. That's a good one. All right, let's go to our next junior fellow that's going to present. Let's go to slide 33. I believe this is Dr. Urken presenting. What you got, Mark?
Yeah, thank you so much for the introduction, Mike. Yeah, I just want to quick note to all of our listeners that by all means, feel free to send in questions. We're going to do our best to try to get to those by the very end here. So next slide. This is a case really where some surgical decision making. This is a 29-year-old female with no other past medical history of any significance, no family history, no radiation exposure. She is an attorney. She lives with a husband, 7-month-old child, and she really was in her usual state of health when she noticed an asymptomatic neck mass that led to an ultrasound. No change in voice or swallowing. Next slide, please. Her physical exam just demonstrated clear enlargement of her thyroid, a little bit worse on the left than, larger on the left than the right. She had palpable disease on both sides of the neck, and fiber optic exam showed normal vocal cord mobility. Next slide. Azita, I'm going to turn this over to you. Do you want to talk a little bit about the ultrasound findings?
Sure. Can we go to the next slide? And we'll just demonstrate. So this was an outside thyroid ultrasound. In the left lobe, there was this, in the upper pole of the left lobe, there was this heavily calcified lesion. It was echogenic with a lot of shadowing, which is always a pitfall when it comes to ultrasound, because once you have this heavy calcification and it has a lot of shadowing, you can't really see what's behind it, and you really need an expert ultrasonographer to talk about the edges and to talk about the borders. Next slide, please. This was in the left lobe. In the right lobe, there was an 8 by 8 millimeter lesion that in the mid pole that was mixed echogenicity. If this is in a transverse plane, the more anterior portion of the lesion was hypoechoic, the more posterior portion was echogenic, but there were some punctate areas of echogenicity within this lesion. This came from outside. I did my own TIRAD. It didn't come with a TIRAD. The TIRAD on the left lobe was 4. The TIRAD on the right lobe was 5. Can you go to the next slide, please? And then also, this is just the sample imaging that I'm showing. There was cystic and septated central compartment, and in addition, level 4 lymph nodes, which I think must have overwhelmed the ultrasonographer, because most of the ultrasound was just demonstrating the lymph nodes. That's it. That's all I have. You can go to the next slide. And
Let me ask you, Dr. Khorsandi, on that last image, is that anything but thyroid cancer? I mean, could this be squamous cell? Because this is.
No.
So tell me why. Tell me why.
Oh, why? So it's cystic. You know, it has some septation because it's really enlarged, but on ultrasound, cystic nodules in the neck or cystic lymph nodes in the neck is pathognomonic for metastatic thyroid carcinoma. There are other features we can look for. You know, there was the earlier case, especially when people are young, we keep getting these reports that there's level 2 enlarged lymph node. You have to lose that fat echogenicity that's in the middle of the lymph node to say these are really pathologic lymph nodes. And the other feature, again, we'll come up with on CT is hypervascularity and cystic nodule, which are calcified also. These are all pathognomonic for thyroid and nothing else.
Gotcha. Mark, go ahead. Next slide.
Okay, next slide. So our cytologic findings were consistent with what we've just heard. And in essence, it led us down the path of papillary thyroid cancer on the left side, and there were bilateral proven metastatic disease. Next slide. This is really where the rubber hits the road here. I'm going to come back to Azita and see if she can share with us what the findings were on CT.
Okay, so I'm only showing you 2 sample images, and I'm going to try to summarize it on these 2 images. So first, let's get to the thyroid. So this was a heavily calcified nodule in the left lobe of the thyroid gland. These are coronal plane CT of a neck with contrasts. The other issue that you guys should all be aware of before I go into the explanation, we've all decreased our MA and our radiation dose when it comes to scanning. It's been a few years, so the images don't look as crisp, the borders don't look as sharp as we want to, but that's because the images are diagnostic enough and we don't want to over-radiate patients. So this is the left lobe lesion. This is the 8mm hypodense right lobe lesion. Based on the images that I'm showing you here, and there is no vocal cord paralysis, I don't see any extrathyroidal extension. In the left side of the neck, if you see what I'm trying to demonstrate is lateral compartment and central compartment nodes. The most prominent feature of these is the lateral compartment lymph nodes, not only level 4, but level 2 and level 3 in this patient. But the central compartment node, if you look at it, this is the aortic arch, it goes into the superior mediastinum. In the right side of the neck, there's a calcified and cystic pathognomonic right level 4 lateral compartment node.
Great. Yeah, so this was, I'm sorry, go ahead, Azita.
Some more images basically showing the lesion in the coronal plane going to the superior mediastinum, which is generally, I've been doing this for a long time with you. This is going to the superior mediastinum abutting the aortic arch has been really unusual to see for us. This is just the lateral compartment cystic node that we saw on ultrasound. Here is, again, you see this calcification and cystic component and a little bit of hypervascularity, again, pathognomonic for lateral level 4 right metastatic node.
Okay. So Dana, looking at this, aside from knowing that you're in for a bit of a longer day here doing the central and bilateral lateral necks, what are your thoughts here on this caudal extent going well into the mediastinum?
Yeah, that's an excellent question. There are a couple of factors that I would take into consideration. One, she's young. She's got a long neck, she's not obese, so that you can get pretty far down into the mediastinum from a neck incision in those kind of patients with a good shoulder roll. You really have to position them well yourself in the OR, but you can go pretty far down with those. And it's classic papillary because it's cystic and all that, and so the risk of vascular invasion is very low. I would say I wouldn't worry about invading the vessels at all. Usually that comes very, very nicely off the vessel walls. So maybe I'm wrong, but I actually wouldn't get a thoracic surgeon in there. If sometimes I do use, I would say, you know, maybe we'll do a meninbriotomy. I use a meninbrial swing. You can take out the upper part of the meninbrium with the clavicular joint and the clavicle, and you can sort of swing the clavicle up and get a little bit more space and get a little bit further down. And that's a nice compromise between, you know, the sternotomy and all that. So if you really need to, and I would probably, you know, warn the patient that that's what's going to happen. I can keep going on this one. It's kind of, and it seems like it's sort of in between the lateral and central neck. I'd like to see, you know, where the innominate vein and arteries are with respect to that on maybe a cross-sectional instead of the sagittal plane. And then I would also really worry about a chyle leak and be very careful about lymphatic, getting the lymphatics controlled during surgery. And then talk to her also about spinal accessory nerve, because she's got those high up lymph nodes as well, and we're probably going to be wanting to do a 2B on the left side as well. So it's going to be a long surgery, but it's going to be a long consultation with her beforehand too.
So Mark,
Great.
if this is my daughter, I want to know from a practical standpoint, are you really going to try to do all this the same day, or are you going to try to clean out part of it and come back a different day? This seems like a really long day for you. I don't want you to get tired at the end of the operation. Is this all going to be one thing, or are you going to stage this?
Yeah, really good question. In my mind, I don't think that there's an absolute necessity. I think you can maintain your attention level and your energy to do this in one sitting. Putting somebody back to sleep again to do this, I don't think serves them well. So let me ask you this, Dana, which side would you start with here? Do you have a preference?
Oh, yeah, I would probably start on the left anyway, just to try, I guess, look at what the recurrent nerve is going to do and that sort of thing. But again, this is a patient, she's got palpable lymph nodes, she's high risk of recurrence. It's, even if I had a loss of signal on the left side with the neuromonitoring that I would definitely use, I'm not sure I would stage the surgery, because it's just, I'm not sure it would really help. I would probably try to get rid of it all at once in one sitting. If I have a loss of signal where I've just been dissecting the nerve nicely and I think it might recover, well, then maybe I'll leave the right lobe, maybe. But this is the kind of cases where I agree with you, Mark. I think I would want to try to get it all out at once.
So based on your conversation, I assume definitely neuromonitoring for this case. So next slide, please. So the real hook in this was that on the left side, we encountered right at the level of the joint that the nerve was going into a mass that clearly was inseparable. And the nerve, no matter what we tried, just could not separate that. So at this point, what are your thoughts in terms of how you would manage that? Next slide, please. So first of all, is there a role for frozen section in helping with your intraoperative decision making?
Is that for me? No. I think if you've got the tumor and you see the tumor is going right up into the entry of the recurrent nerve into the larynx, I don't think I would. I use frozen section for trachea when I'm resecting the trachea to see if I can get clear margins, but I'm not sure that I would use frozen section to do that. It's hard. It's a very hard decision to make. If you're going to leave some macroscopic tumor, even a small, but you have to leave a small bit of tumor that you actually see. So that's R2 resection. Or do you resect it to try to get R0 resection in that area? And it's a really tough call. I think she's young. She's got classic papillary that's probably radioactive iodine avid. She might even have lung metastases that we haven't seen yet. So I think that maybe I would err on the side of caution and try to keep her nerve. She's a lawyer, so I might want to keep her nerve, leave a little bit of tumor on that nerve. The neuromonitoring in that case would be indispensable. And actually, I don't use it a lot, but the continuous neuromonitoring can actually, when you're dissecting the nerve, sometimes you see that the nerve kind of starts to suffer, and so you sort of stop what you're doing. So that could help to try to get as much tumor tissue off that nerve as possible. But yeah, I would maybe err on the side of a little bit of gross disease in this young patient who needs her voice and who's probably radioactive iodine avid. But
so
Dana, may I ask you, why wouldn't you use frozen section in this situation?
Well, because basically, the tumor, we use loops, and I would see the tumor, and usually you can see it kind of stuck on the nerve, and you can see it stuck onto the epineurium. And you can actually see, usually there's sort of these really gross sort of looking vessels on the nerve as well when it's sort of invaded like that. So I would, I'd leave a small patch, but I know it's tumor.
Yeah,
So I
okay.
don't think I would, yeah, you know what I mean? It's, I
Yes,
to
we'll
see it.
get to that in a moment.
Yeah, okay.
So my thought in this was whether there's a role for frozen to tell you if indeed this portion is indeed well differentiated disease. Would you stop at this point if you were starting on the left side to go to the other side and make sure that the contralateral nerve was indeed dissectable and can be demonstrated to be functioning?
Yeah, probably. Probably I'd stop, leave it, go to the other side, clear out the other side. And that would give you time to think about resecting or not resecting.
Yeah, so at the end of the day, this there was just no. I did go to the other side, did clear that nerve. It was demonstrated to be functioning well, and the real question here was, how do you manage this in terms of, do you resect it, knowing that at that point you're committing obviously to a vocal cord paralysis? Your point about age is extremely important, but if you're leaving gross disease behind there, you may be going down a pathway that really is going to condemn this patient in the future if she recurs to a difficult surgery. And I'm not sure that there is any really great evidence to support this one way or the other. Any other panelists want to comment on this, just in terms of the decision-making process?
Can I say something? I'm glad you said that, because usually what I do is resect. But I have a case, he was 18 years old, and I resected and I felt really bad, and then we have other cases where I left it and he had lung mets, and so he had to have 3 administrations of radioactive anyway, and the thing disappeared in the neck. So it's really a tough call, I think.
Yeah,
I agree. I mean, it's definitely a tough call, right? So Dana alluded to it. It's the part of the decision making is the likelihood of RAI responsiveness, right? If this was a poorly differentiated, a Hartl cell cancer, that's a little easier decision, but that's usually not in young people. And we've all seen cases of these classic papillary thyroid cancers in kids melt away 1 and 1.5 centimeter places. So, to me, I had to ask the surgeon, okay, if you leave gross disease behind and I give radioactive iodine and it doesn't work, yeah, she'll lose the nerve at some point, but can you still, make sure we don't have to get into the trachea or the larynx or something like that? So, sometimes it's involving the nerve, not right at the joint, right? If it's involving it someplace else. This one I think is hard because I'd have to go to Mark and go, okay, if radioactive iodine didn't work, what would salvage therapy look like? Would it just be cleaning out the nerve and leaving the larynx, or are we condemning it? So to me, it was sort of that second step about what the salvage would look like. I agree. I mean, the general approach is resecting gross disease, right? That should be our set point. That's the oncology. That's our best outcomes. But on ones like this, we have definitely left some gross residual disease at the nerve. Dr. Pitoia, what do you think?
I agree. Completely agree with this. And mainly, we would probably leave disease if we think that this patient is having a Hartl cell carcinoma or something like that, that we can use external beam radiotherapy or something like that, more than radioiodine. But gross disease, we want it outside.
Great. So,
Dr. Tuttle, can I answer the panel? Somebody's asking questions about the cystic lymph node. Before we run out of time, can I just answer?
Please. Yes, please do.
HPV disease does cause cystic lymph nodes in squamous cell carcinoma in young people, but this is a 29-year-old with central compartment going to mediastinum. It would be very unusual. 29 is young, although I have to say in the past few years, I've seen one 25-year-old had an HPV squamous cell carcinoma, but 29 is still younger than the squamous cell carcinomas that we see that are HPV, and the location is unusual. So sort of have to use my common sense a little.
Agreed. Gabby, jump me to slide 55. Mark, we got 2 minutes. Finish this out for me. Slide 55, Gabby.
Well, all right, let me take it from here. Go backwards, please, to the report.
You got 1 minute, Margie.
Okay, sure. Just go backwards. So I can go over the report. Okay, fine. So in summation, she has a 1.6 classic and follicular variant PTC, no tall cell component, and that was T4A because of the gross ETE. The left cricothyroid joint was positive. And then on the right lobe, she also had a 7-centimeter PTC with tall cell features, no ETE. She had 10 of 60 positive lymph nodes, the largest being 5.5, with E&E in 2 lymph nodes. So she has aggressive lymph node status. Aggressive disease, not really predicted by the morphology, but of course, the fact that the part I, as you see here, the cricothyroid joint is positive, as was part A, that really predicts the outcome in this case. Just quickly advance 1, 2.
It's 9 o'clock.
3, 4, 5. Okay, here's a positive margin. Here's the cricothyroid joint. Next slide. Here's the nerve, which was negative, but as you can see, it's surrounded by small islands of PTC.
And one more thing in retrospect in CT, if you look at the medial border of this lesion, it was irregular, and I should have raised the issue of extrathyroidal extension. In retrospect.
30 seconds, Mark. Close us out on this.
Yeah, I think it's, I think the real take-home message in this is really some of the uncertainty, and there's just no real great evidence to support the decision-making when you encounter a functioning nerve with tumor encased in a difficult area. Mike and I share a patient where chose to choose the more conservative route of leaving some small volume disease at the level of the joint and proved not to be responsive to radioactive iodine. So hindsight is always 20/20. I think in the interest of time, we've gone over the hour. I want to thank all of our panelists. And if there are any remaining questions, I think there were some on the chat we just didn't get to. But thank everybody for joining us. I think this was really an awesome session here.
Fantastic. Thanks to the panelists. You guys did great. Have a wonderful day or night.
Thanks.
Thanks, Steph. Bye-bye.
Thanks, everybody.